Hello, my name is Dr. Dan Hindley and I work as a community paediatrician in Bolton in Greater Manchester. This is the first of 3 e-lectures on community paediatrics, and the lectures are based on questions from the extensive PASS test database. I really hope that these lectures will provide you with some insight into the sort of questions you can expect to have to answer on this aspect of paediatrics for MRC PCH Part 1. This lecture covers examples of questions about child development. The learning objectives for this lecture are as follows. To revise the key developmental milestones and domains, to understand the range of normal development, to recognize abnormal patterns of development, to be familiar with causes of developmental delay, to know when and how to investigate developmental delay, and to know about the multidisciplinary aspects of management for developmental delay. As you'll probably remember from your undergraduate days, development is difficult to revise and difficult to keep in the front of your mind unless you're dealing with it on a regular basis. I would say that the key stages for developmental milestones are as follows: an infant of 6 weeks, a baby of 4 to 6 months, a baby of 9 months, a baby of 12 months, a toddler of 18 months, and a young child of 2 years, 3 years, 4 years and 5 years. The key domains to consider when thinking about child development, and there are a number of different ways of thinking about this, I'd prefer the one proposed by Illingworth. Key domains are gross motor skills, manipulation skills, general understanding, speech, and sphincter control / miscellaneous. Question 1. A normal 6-month-old baby should A. Hold an object between finger and thumb, B. Have progressed beyond palmar grasp, C. Lost Moro reflex, D. Roll over from front to back position, E. Show hand dominance. When we consider this question, this is looking at what a normal child should be doing. This is a typical MRC PCH question on child development. And as you'll know, a normal 6-month-old baby should be able to roll over from front to back and readily follow objects with their eyes, use a good palmar grasp, and transfer objects from hand to hand. Babies of this age would also recognize parental voices and babble and laugh. Pincer grip is usually not seen at this age, but from about 9 months of age. And the Moro reflex is present from birth and persists till about 3 or 4 months, and it's abnormal for the Moro reflex to persist beyond this stage. And if it does, motor delay should be considered. Hand dominance is unlikely before the age of 18 months, and if there is early hand dominance, then this should alert a clinician to possible brachial plexus injuries or hemiparesis. So the answers to this slide are A equals false, B equals false, C equals true, D is true, E equals false. Question 2. This is a similar slide. The average 1-year-old child, A, can pick up 100 and thousands with an accurate pincer grasp, B, can walk unaided, C, can talk in sentences, D, can understand the concept of object permanence, E, will have been vaccinated with the MMR, that's the measles, mumps and rubella vaccine. At the age of 1 year, children should have developed an accurate pincer grip and to be able to see and coordinate and manipulate small objects, such as the classic 100 and thousands. Gross motor development varies. but the average 1-year-old should be able to stand and cruise, but not necessarily walk unaided. The average 1-year-old will have developed object permanence. It is important that you know the UK vaccine schedule. This changes very frequently and it's important to keep up to date. Currently, the Hib and Men C booster is given at 12 months and the MMR is given with a pneumococcal booster at 13 months. So, the answers to this question are A equals true, B equals false, C equals false, D equals true, E equals false. Question 3. Which of the following would imply the need for developmental assessment in a 2-year-old child? A. Still only able to go upstairs 2 feet per step. B. Inability to match 3 or 4 primary colours. C. No intelligible words. D. Failure to make a 3-block tower. E. Bedwetting. This is a slightly different sort of question, asking about red flags which would suggest the need for a more detailed developmental assessment. It is normal to go upstairs alone and down holding on 2 feet per step at 2 years. Children can normally name 1 colour at 3 years, 2 or 3 at 4 years, and 4 colours at 5 years. A 2-year-old would be expected to build a tower of 6 or 7 cubes. A 3-year-old copies a circle with a pencil and imitates a cross. They would copy a cross at 4 years and a square at 5 years. Bedwetting is obviously not abnormal at this age. So the answers to this question are A is false, B is false, C is true, D is true, and E is false. Question 4. A 48-month-old child should be able to A. Copy a cross shape, B. Dress with supervision, C. Name 10 colours, D. Draw a 6-part man, E. Talk in clear sentences. So this concerns the developmental achievements of a normal 4-year-old child. We've discussed some of these in the last question. A 4-year-old child may well be able to name a few colours and to draw a basic man with head, limbs and sometimes maybe a body. A 4-year-old child would normally be able to dress with supervision and talk in clear sentences. You'll be familiar with the Good Enough Draw a Man test, which starts from around the age of 3. So the answers to this question are A is true, B is true, C is false, D is false, and E is true. Question 5. The child should be investigated further if they are not A. Sitting unsupported by 6 months of age, B. Smiling by 4 weeks of age, C. Walking alone at 12 months of age, D. Saying single words with meaning by 18 months, E. Dry at night by 3 years of age. This question is not asking about the range of normal, it's asking about when investigations should be instigated. A 6-month-old child would be expected to pull to sit and to stay sitting momentarily, but not to sit unsupported for any length of time. Smiling often occurs by 6 weeks of age, often before that, but we wouldn't be concerned until about 8 weeks of age at least. Walking occurs any time from 12 to 18 months. The failure of children to say single words at 21 months should raise concern, but there is wide variation, with girls speaking generally before boys, and 2-year-olds can vary considerably, some only having a few words and others having a vocabulary of up to 2,000 words. Children are usually expected to be dry by day at the age of 2 years and dry by night at the age of 3 years. However, 10% of 5-year-olds and 5% of 10-year-olds will still wet at night. So the answers to this question are: A is false, B is false, C is false, D is false, and E is also false. Question 6. In an otherwise well child, which of the following are indicators of possible language delay? A. No single words by 18 months of age. B. A family history of hereditary deafness. C. Failure to construct 2-word phrases by 30 months. D. No repetitive babble by 8 months of age. E. Echolalia at the age of 2 years. Most infants will be vocalizing tunefully by the age of 4 months and using strings of repetitive same sound syllables, for example, aga-ga-ga or da-da-da, from 7 to 8 months of age. But there is a range of normal behaviour, and most referral guidelines suggest 10 to 12 months as an upper limit for babbling. Monotonous or limited vocalization after 9 to 10 months should arouse suspicion of deafness. Echolalia, which is repeating phrases others have used, is common at 2 years of age. And failure of children to say single words by 18 months should raise concern. A child with a family history of deafness should be screened during early childhood, and in fact most babies are now screened in the neonatal period on the universal hearing screening program. There should be a hearing test performed whenever parents express concerns regarding their child's ability to hear properly. So the answers for this question are: A is true, B is true, C is true, D is false, and E is false. Question 7. Children should be referred for a hearing test: A, if there's no intelligible speech by 3 years, B, if there are no single words by the age of 18 months, C, if there is parental concern regarding the child's hearing, D, following bacterial meningitis, E, if there is a strong family history of deafness. As we mentioned in the previous slide, children should be referred for a hearing test if there is parental concern regarding the child's hearing. All children who have had bacterial meningitis or were suspected of having bacterial meningitis should be referred for audiological assessment, as should children where there is a strong family history of deafness. Other indications for referral include no intelligible speech by 4 years and no single words by the age of 21 months. So the answers for this question are: A is false, B is false, C is true, D is true, E is true. Question 8. Causes of developmental regression typically presenting beyond the age of 2 years include: A, hypothyroidism, B, HIV encephalopathy, C, subacute sclerosing panencephalitis, D, mitochondrial disorders, E, amino acid ureas. It's always important to look out for loss of already acquired skills when taking a developmental history. Recognized causes of developmental regression beyond the age of 2 years are many and include subacute sclerosing panencephalitis, very rare in developed countries following the introduction of effective measles immunization. Also, other acquired CNS infection including HIV and prion disease, leukodystrophies, Wilson's disease, other neuronal storage and mitochondrial disorders. Developmental regression before the age of 2 years is typically seen in hypothyroidism, amino acid ureas, and some of the lysosomal storage disorders, including certain of the mucopolysaccharidoses. So the answers to this question are: A is false, B is false, C is true, D is true, and E is false. So those are the 8 example questions for this lecture. The key learning points for this lecture are that there is a wide range of normal in child development. It's very important to know what is normal and what is not. It is very helpful to carry a snapshot of average achievement at key ages, as mentioned at the start of this lecture. Early recognition of significant developmental problems is vital, and identification of causes of developmental delay by appropriate investigation allows a tailored management plan. I would suggest that Illingworth's textbooks regarding the normal child and normal and abnormal child development are very good sources of information on this subject. This is the end of the first lecture on community paediatrics. Lecture 2 covers child protection, and Lecture 3 covers immunisation and public health issues. Good luck in your work.